shoulder osteoarthritis, night pain, activities of daily living are limiting. You can ask about the daily living activities like eating, brushing hairs, personal hygiene. On examination, look anteriorly, lateral, and posteriorly. You can feel for the wasting of the rotator cuff. A geyser sign is important. There is a fluid collection at the ACJ joint, indicates effusion and synovial fluid free to communicate between the glenohumeral and subacromial bursa. This can also be caused by acromioclavicular joint cyst. The sign is called geyser sign. Feel for the bicep tendon. Check the range of motion. Functional movements are hand to mouth for eating and shaving, behind the hair for brushing, and back for wiping the bottom. An X-ray is true AP, 30-degree angle in coronal plane, and axillary view to look for posterior glenoid wear. A CT can be indicated if there is large loss and assess the glenoid wear, version, and overall bone stock. Regarding rotator cuff arthropathy, this can also cause arthritis. The subtle signs can be: number 1, anterior-superior scape of the humeral head; number 2, acromial acetabularization; number 3, anterior subluxation on axillary view due to damaged subscapularis; number 4, pattern of wear is typically superior and posterior; number 5, biomechanically occurs because of loss of fixed fulcrum called concavity compression function of the rotator cuff, resulting in unopposed deltoid action. How to manage? Number 1, non-operatively, physiotherapy mainstay, improve range of motion, improve deltoid function. Patient with rotator cuff arthropathy can benefit from subacromial decompression and bicep tendon decompression if needed. Other option is hemiarthroplasty. Best indicate for AVN trauma and poor glenoid bone stock. Trauma stems have holes for GT and LT attachment. It's most advisable in young patient. High risk of glenoid replacement loosening can happen. That's why it should be advised. In case of rotator cuff arthropathy, this must have deltoid and coracoacromial arch. The results are inferior to the total reverse shoulder replacement. For hemiarthroplasty, the implant height is important. The tip of greater trochanter is 10 mm below the tip of the articular surface of humeral head. Number 2, distance from the top of the prosthesis to the upper border of pec major is 6 centimeter. So these are important landmarks: 10 mm GT and 6 centimeter pectoralis major. Common cause of failure is greater tuberosity redisplacement or non-union. There are role of pyrocarbon heads which are being utilized as well. Regarding resurfacing, main anatomy is by placing the prosthesis in the native anatomical location. It is a good option for young people with preserved bone stock, but it is easy to overstuff. Smaller operation and reduced risk of redislocation if you are doing resurfacing. Number reducing as total shoulder and hemiarthroplasty are more consistently done.